Questionnaires for Sleep. We are delighted to have you all for this intellectually enriching day dedicated to advancing our understanding of sleep-related disorders and their clinical management.
We are once again honored by the esteemed presence of Dr. Christina Franz Ma'am, an eminent expert in the sleep science. We look forward to engaging in today's intellectually stimulating lectures. As today marks the end of this 5-day program, I request you all to make the most of it and gain maximum benefit. Let's begin with our first session of the day, which explores sleep bruxism, a condition often overlooked yet significantly impactful. We invite Dr. Christina Franz Ma'am for this session.
Oh, perfect. I think I'm going to take these two. Yeah, I think so. That's okay, I can handle it. Yeah, we have. Hi. Okay. Good morning, everyone. I'm going to be seated today because I'm also tired, just like you are. Last day of the course, lots of new things going through the mind. So, we are talking today about sleep bruxism, then narcolepsy, and then circadian rhythm sleep disorders. To start, sleep bruxism, we have the concept. Sleep bruxism is a repetitive jaw muscle activity characterized by clenching or grinding of the teeth and or by bracing or thrusting of the mandible during sleep. So it's called a movement disorder of sleep. Here we have a video that I want you to see. We are not listening to anything, but just have a look at how this guy thrusts his mandible. Can you see that? He makes some movements and then he wakes up, turns to the side, and continues make it. And then he wakes again, try to turn to the other side. So as you can see, the events of the sleep movement disorder called bruxism, sleep bruxism, are happening throughout the night. Thank you very much. And the events are making, he's just a report that he's saying how tired he was on the next day. So the movements, the biggest thing is that it fragments sleep. The person wakes up a lot during the whole night. So one of the main features, one of the main characteristics of sleep bruxism is sleep fragmentation, okay? This is a disorder that we treat together with the dentists. This is a movement disorder that can occur both during sleep, then it's called sleep bruxism, and can also occur during awake, then it's called awake bruxism. They are almost the same thing, but are different entities and treated almost in the same manner. But sleep bruxism is a very common condition. About 80% of adults grind their teeth during night. So we are going to go deep into those things here. It can be primary, someone can just have it, or it can be secondary to another condition or using of drugs, for example, or medications. I have some patients going on lithium for psychiatric disorders, and they start to have complaints of sleep bruxism. It is often associated with anxiety and hyperactivity. So anxiety is something that we must pay attention in our patients, because sometimes we need to treat this anxiety, need to refer the patient for psychology or psychiatry before start treating the sleep bruxism. Some possible mechanisms that this sleep bruxism may occur. Just let me get the pointer. Yeah. Some possible mechanisms that can lead to sleep arousal is this autonomic and motor dysfunction. So we will have interaction with sleep and vigilance network. We can also have some influence of the circadian and ultradian rhythms. So the feeding cues might be not properly given. And then these could lead to anxiety, stress, and other things that in turn could lead to sleep bruxism. We can also have some deficiency or differences in neurotransmitting. Genetics always plays a role, but I think one of the most important things in sleep bruxism is the personality, anxiety, and maladaptive coping. So, sleep bruxism can lead to abnormal wear of the teeth, as you can see in this image here. And it can lead to pain in the teeth, in the jaw, in the temporomandibular joint. Can lead to headache, tooth sensitivity, and sleep is disturbed, both for the patient and for the bed partner. So when we have a patient and we look into his mouth, we can see if there are any possible signs that you could suspect of sleep bruxism. And in case of yes, you just send to a dentist. Well, I think this is another profession that is growing a lot, just like physiotherapists. They are the sleep dentists. Okay, so if you have friends that are dentists, you can tell him about sleep and say, oh, there is a new area that you can go through. You can treat sleep bruxism. You can treat sleep apnea. I think those two areas are going to grow a lot as we gain knowledge about sleep science, okay? So here we see some clinical features like masseter hypertrophy. You see, I have a little bit here. And we can see here in this gentleman, in this lady, here also. So masseter hypertrophy is something that may be present. It's not in every patient that you are going to see this. Of course, we have all those intraoral findings that you can see. You see states of erosion in the teeth. You see that there are some states that the clenching is going on here. We can see some wear, like mild ones or moderate or even severe ones that the gums are exposed. So these things we have to look for. There are also fractured tooth, cracked ones. Patients can fracture the root and things like that. So we just ask for how is your dental condition? How long you've been to the dentist? Okay. And then we come to something that we physiotherapists are very used to treat, that is pain and range of motion. Some findings of sleep bruxism can be pain, limitation of function, reduced range of motion. So patients will complain about pain when sleeping, when chewing something, even when chewing hard things like meat, okay? They say, oh, I can't go out to a barbecue with my friends because every time I go, I had lots of pain. They also have discomfort, fatigue, tension, difficulty with the jaw movements or maybe with the neck movements when waking up. And then can wake up with pain, with lots of tension, sensitivity, tooth sensitivity, and also may present headache. The impact of sleep bruxism on sleep architecture is that we have fragmented sleep, an increased time for sleep latency, so it takes longer to go to sleep, increased time of N1 sleep stage, might present nocturnal myoclonus, and we have this alpha wave intrusion into delta sleep that I'm going to show you a picture so you have that in mind. We have these abnormalities that are compatible with increased anxiety and depression, and shortened sleeps, slow wave sleeps, the deep sleep, okay, N3 sleep stage, deep sleep. So here you see an example from the work from the group of the Dr. Gilles Lavin in Canada. What we see here is that these black arrows show us that these are N3 stage, so deep sleep, slow wave sleep. And in between those slow wave sleep, we have these little ones here that are the alpha sleep. So we call that alpha wave intrusion into delta waves. This is a very common characteristic of pain patients. And it's very common to find in the PSG. This one here, just a curiosity, but this one here was the alpha into theta waves was discovered by Moldovsky about 50 years ago in fibromyalgia patients. Fibromyalgia was at the beginning it was called the sleep disorder, okay, because of this very, very intrinsic relationship with sleep. It was, and it's not any longer. So how can we diagnose sleep bruxism? We, as a physiotherapist, we cannot. But the dentist will ask, if the dentist will have a patient with a possible diagnosis, a suspicion, he will conduct an anamnesis and see if there is a report of teeth gritting by the patient or by the bed partner or by someone in the family. And we'll see if the patient reports jaw muscle tightness or other pain or discomfort. And the gold standard, again, for the diagnosis of sleep bruxism is a polysomnograph, as we have seen. It might be associated to audio and video recordings to record the masticatory movements or the contraction of these movements, of these muscles, that can be evaluated. So in I think November, December of 2023, the International Classification of Sleep Disorders launched a text revised edition in which the criteria for sleep bruxism was the presence of repetitive jaw muscle activity characterized by grinding or clenching of the teeth during sleep, and the presence of abnormal tooth wear and transient morning jaw muscle pain or fatigue or temporal headache will be consistent to the reports of tooth grinding during sleep. So dentists will use now these criteria to diagnose sleep bruxism along with the PSG. Here we have, remember that I told you in the PSG lecture about the sleep bruxism montage, the way the electrodes are placed. So you see a lot of electrodes going on the face and all the muscles from this patient. So this is how it looks like, the sleep bruxism montage for the polysomnography. And here we also have an obstructive sleep apnea, desaturation, and the lack of a little bit of the effort in the belt. But what we see here is the right electrodes showing these phasic movements, and here the left electrodes. So we have this pattern, this repetitive pattern going on. And while these muscles should be relaxed, they are in an involuntary manner working. Sleep bruxism is another of the sleep disorders that we don't completely understand what's going on. So there are some evidence talking about the possible consequences that exists for sleep bruxism. One of them is this sympathetic activation. So we would have a rise in the sympathetic cardiac activity occurring between 4 to 8 minutes before this rhythmic masticatory muscle activity. And then we will have an increase in the EEG frequency 4 seconds before that happens. 1 second prior to the rhythmic masticatory muscle activity, we will have tachycardia. And then we will have almost at the same time, the suprahyoid muscle activity will increase. And in some individuals, a big breath could also be noted. So this rhythmic masticatory muscle activity occurs in the masseter, resulting in tooth grinding. So this consequence does not occur in all these movements, but it's primarily associated with young subjects, young and healthy subjects. So as we can see, we have an autonomic cardiac activation occurring in sleep bruxism. The symptoms that we have are the squeaking, clenching that may produce some noise, teeth clenched when waking up, this feeling of tension and feeling of stiffness, waking up with restricted movement, discomfort in TM joint muscles, difficulty in opening the mouth, complaints of temporomandibular joint and cervical pain, neck pain, morning tension, hypertrophy of the masseter in some patients. In some cases, we can also have change in the symmetry of the face because one side can be stronger than the other. These blue ones here are the symptoms that physiotherapists can treat. And these three here are the symptoms that the dentists can also treat. So excessive tooth wear, injury to the edge of the tongue or inside the cheeks or even the tooth itself, and the sensitivity in the teeth and or in the gums. And how is sleep bruxism with how frequent it is with other comorbidities? It will be not very, but it will be easier if we could treat just one disorder. But what happens most of the time at the patients presents disorders along with other sleep disorder and with a medical comorbidity. So that is really a challenge for us to treat. Sleep bruxism is very, very common with obstructive sleep apnea and with insomnia. So these three disorders, they can be presented together in different manners. Bruxism and obstructive sleep apnea, bruxism and insomnia, okay? All the three of them together. But we know that all of them lead to arousals. So this is one of the main things, the main features that we need to address. And this will, of course, lead to a complaint of poor sleep quality in most of the time and fragmented sleep. So we have this evaluation map that we made in the Brazilian Sleep Consensus, trying to make it simple. So we would start with the anamnesis of the patient, asking these questions. So, do you grind your teeth? Has anyone ever heard you grinding your teeth? Do you feel teeth, any gum pain or aching when you wake up? So you ask a lot of questions to the patients. If they say yes, you refer to the dentist for diagnosis. But if you see that they also have complaints of fatigue, drowsiness, unrefreshing sleep, reflux, and if you see that you're talking to the patient is biting the nail, clenching a pen, a pencil, or something, or is making some strange movements all the time, then you see that this patient may have parafunctional habits that you must address. If you note stress and psychological conditions, or the patient says he went through previous psychotherapeutic treatment, you might consider refer this patient to psychology. And then you have the clinical evaluation, where you will see the masticatory musculature, the neck and thoracic spine, and the upper limbs. So exactly the same idea that when we treat patients with pain, we can have these drawings here where the patient will draw where they feel the pain. And you have something to compare between before and after treatment. So this material is on the reading materials that you will all get at the end of the course, okay? So I strongly encourage you all to have a look at that, especially for those who want to work with sleep bruxism. After having the physiotherapeutic assessment per se, you can see if the symptoms are absent or present, and then proceed to treatment. The treatment can be arranged in various manners. We are going to go through that right now. So we can have relaxing exercises, some forms of currents like TENS or microcurrents. We can have dry needling, acupuncture, nasotherapy, myofascial therapy, okay, massage. There are no validated questionnaires for sleep, okay? So I added this here because I know you've already have had a lecture with Professor Zubia about the sleep questionnaires, but there are no questionnaires specific for sleep bruxism. But there is this STAB, as a standardized tool for the assessment of the bruxism. This is being working by this group of Canadians. They are a very strong group in researching about sleep bruxism. And this consists mainly of two axes: the evaluation of the evaluation and the consequence of the sleep bruxism for the patients. So it's a very long questionnaire with 66 questions. So it's something that I can't perform in my daily practice. It's something related more to research. And it's kind of a new thing. So we are starting to use that in research. What about the treatment? The treatment, it mainly consists of a combination of what we call the 5 P's. The first P stands for oral appliance or occlusal plate that will make the teeth secure and not to break or to have any damage during sleep. So this is, we have in the market, some of them are already made. You just buy them, and with the warm, sometimes you have to put them in warm water and then put in the mouth, and then we get the shape of your dents, of your tooth. But the best ones are those ones that the dentist can make specifically for yourself. Some physiotherapists that work daily with these patients say that sometimes patients complain that using this oral appliance make it worse. So we need to see what's going on, because proprioception can be affected, and patients having this thing in the mouth would go for more stretching, for more strengthening and gritting of the teeth. So the other P stands for psychology or PEEP talk. These are behavior strategies. So if patients with sleep bruxism are very anxious and have a huge chance of having mood disorders, we need help from psychologists. The other P stands for pills, central acting drugs. So sometimes a physician together will also help these patients. The professional, the team collaboration, the interdisciplinary work, transdisciplinary work is a must for the patients with sleep bruxism. And us. We deal very well with these pain issues and with the education of the patients, because we see patients a lot of times during a week, during a month. So, what are the objectives of this non-pharmacological treatment? Well, we have to manage the pain, to reduce the muscle activity, to rehabilitate the function of temporomandibular joint, to normalize the range of motion, the positioning of the joints, to relieve the mechanical stress, to normalize proprioception and muscle balance, to improve oral habits, to prevent muscle compensation, and to avoid the involvement of other regions such as neck and thoracic spines. And how we do that? We do that through therapeutic exercise, relaxation techniques, manual therapies, acupuncture and dry needling, electrotherapy, stretching, low-level laser therapies, and behavior guidance. I know it's too small here. I'm sorry about that. But we performed in this Brazilian consensus, we reviewed the literature and we tried to take some evidence from them from what we had. We still doesn't have much of evidence regarding physiotherapy treatment for sleep bruxism. But what we saw here, you see the strength of the evidence. Here is B, here is C, and here is not recommended. So the evidence B is something that we can work in our practice, like laser, educational and behavioral guidance, transcurrent electroneural stimulation current, PNF associated myofascial release, microcurrents, and relaxation exercise. So we are talking about them just right now. The C stands for something that we have some research in literature, but not with good sample sizes, and maybe we have just 1 or 2 research, so we need to research this more. And this is static and isometric stretching, dry needling at the trigger points. In Brazil, we have a specific formation for dry needling, acupuncture, kinesiotherapy, myofascial release, and what is not recommended because we don't have evidence is the transcutaneous, the TENS thing applied to the face muscles, to the neck, okay, to the face we don't have evidence, so we don't recommend that. And kinesiotherapy as a standalone therapy is not recommended. Therapeutic exercise of muscle strengthening are always not recommended. And manipulation and mobilization of the vertebrae, we have no evidence to support the recommendation of that. So you can see that the entire paper in the material that I have for you. This is a very nice evidence in literature. This is a comprehensive review of the Dr. Simone Go, and she writes about the importance of having stretching exercises for these patients, because they will improve the range of motion, prevent injury, improve performance, and there are a lot of evidence showing that will also improve the viscoelasticity and therefore the range of motion and the flexibility. So she describes each type of the stretching, passive, active, ballistic, or PNF, and these main characteristics. So this is a paper that it's very interesting for you to have a look. Here are some therapeutic exercises that we can teach the patients to do in our sessions, and then they can take a booklet at home and make it every day. There are also some apps that they can make the exercises and put in the app how many sets they did and everything like that. So we will have a record of everything that they did. There are some evidence on manual therapies. For example, this one, try to see if massage or only the using of this oral appliance, and both of them together, so they had these 3 groups, to see what's the effect they would have on EMG and if the symptoms of bruxism would reduce. And what they saw is that both massage and the splint alone, they didn't have any effect on the EMG. But when combined, they didn't have any effect on the EMG, but they reduced the intensity of the symptoms. So combining the therapy is a good thing. This other study also have about the same results. They performed about the same thing, and they had a lot of reducement of the pain when combined therapy was used. So physiotherapy and the dentist together can make better for the patient. In this one, they compared the occlusal splint and the kinesiotaping, and they saw that when combined again, they had reduced the pain, increased the range of motion, and they say that one therapy is just efficient as the other one. But the result showed that the therapies alone didn't work so well, but when combined, they worked perfectly. So I think we should think about always having combination of therapies. Here are some manual therapies that we can deliver to the patient. So we have like external ones and internal ones that we go through. The internal ones are very painful, so patients complain a lot, and sometimes they have headache or stomach aches because we are making movements inside the mouth. And I don't know if any of you works inside the mouth of the patients, but this is something that we had a lot of trigger points. Okay, we can feel in our fingers the trigger points of the muscles internally. Also, we can have all the trigger point myofascial and manual therapies from the outside. Another thing that helps a lot, but we need to search for more evidence, is acupuncture or dry needling. Do you know the difference between them? Yes or no? The difference between acupuncture and dry needling? They are different things. Okay? Acupuncture, they both have the same material, so you have a needle, but the acupuncture, you might treat the sleep bruxism by putting the needles in your knee, for example, because the meridian that you need to treat is there. And the dry needling, so you have the philosophy of the traditional Chinese medicine behind that. So you can treat not only locally, but you can treat systemically. In the dry needling, you go with the needle exactly in the trigger point. So you will release it. So you have no philosophy behind that. We also have some research combining here. You see the dry needle and the TENS, okay? I have good results with this in my daily practice. The patients, they say that it works, it's better than when it's without the electrotherapy. But this is really, really annoying. It hurts a little when you use it. So not every patient can stand to be like half an hour or 45 minutes receiving this. There are some new devices coming on. I say new devices, but this one is from 2013. But the research is old, but the devices are, I think, about 8 years, 5 years in the market. So these are TENS units that patients can apply. So this is called grind care. You might note that you have a look at it later. So grind care is an electrostimulation that will help. We also have some wireless devices that are coming into the market, and some of them, like this one here, it would detect the movement of the muscles before the masticatory movement happens itself, and then it will release slightly tension to relieve the muscles in order not to have the written masticatory thing. But this is a new research. We don't know the mechanisms exactly of what's going on here. So it's something that I think is for later. We also have these laser things in specific points that might help. In Brazil, dentists use that also a lot, but physiotherapists also do. And we also need to go through with the patient into these behavioral and changing habits, mainly for these parafunctional habits that we spoke about. So patient education is a must. We need to have maybe relaxation, hypnosis, go through the sleep hygiene rules, and cognitive behavior therapy is not only for insomnia. There are specific ones for insomnia that we call CBTI. I stands for insomnia. But in sleep, you will always see the CBT thing. So we might have CBTB for bruxism, CBTS for sleep as a whole, and goes like that. And there is this app, Brux app, that we can see if the patient is having any trouble. It is a paid one, and the patient would wear those stickers, and we would monitor if the treatment is going on well or not. Well, let's go through a clinical case. It's not my case. I'm going to present you the case of the Canadian group. So I invited Jacqueline Yam to write this for the book. And she spoke about a patient that she had that was a female, 29 years old, with a long history of orofacial pain. And she had some diseases and didn't present any sleep disorders. In 2018, she had the dental diagnosis of sleep bruxism, and she received the occlusal splint to prevent it and to reduce the damage. Then, 1 year later, she had recurrent acute episodes of severe orofacial pain. It was like 8 in 10. So she was sent to Jacqueline for physiotherapy. They started together to perform some exercises and manual therapy, aiming the improvement of the muscle and joint pain. But it was only with exercising of other body parts like head, neck, and shoulder that they got the pain reduced. So what got her idea at that time was this severe orofacial pain. And this is a drawing of the patient. So the patient drew pain sites, what she was feeling the most. And the Jacqueline performed postural assessment and saw chest rectification, anteriorization of the head, and things like that. The patient also complained about tension headache. The symptoms went worsened when she was in stress. And although in autumn, she complained that every autumn she had more difficulties, but she had some improvement with yoga and with swimming. And she slept in prone and lateral decubitus. She went through a neurological examination of the cranial nerves. Everything was okay. She had a weaker tongue resistance on the right side compared to the left side. She was right side. The right side of her was dominated by pain and muscle spasms, both with intermittent occurrence. She measured the mouth opening, and there was a decrease in the extension and left lateral flexion of the neck spine, with a report of pain at the end of this range of motion. So they needed to, she had an increased neck flexion and the scapular position was okay. But they saw other postural things was going on with her. And then they had the functional tests and the arthrokinematic evaluation of her. And they started treatment once a week for 1 hour with the dry needling sessions for 1 hour and a half. So this 1 hour was for education. And all sessions included postural education, education about stress, pain, and exercise. They also had a combination of manual therapy and myofascial release. And the patient said that myofascial release was what helped relieving the pain and increasing the mandibular range of motion. So this is a set of exercises that is printed in the book. So they went through each of these exercises in the PT sessions, and then the patient was able to learn how to perform this exercise by herself at home. So they did assisted rotation, isometric neck flexion, resisted head push back, isometric neck side bending, anterior wall side with this myofascial roll, wall side. So she stood in the wall and tried that to hold that for a little bit. Resisted mouth opening and lateral deviation of the mouth also resisted. So they performed about 10 seconds or 1 to 5 times, 1 to 5 minutes each of these exercises. And they also have some things specifically for the mouth and the tongue, like tongue protrusion, tongue stretch, lateralization straightening, isometric diagonal jaw, mouth controlled opening in front of the mirror. This is something very nice to perform with the patients. And we also need to show the patients how they can release the soft tissues by themselves at home if they feel something. So in 3 years of treatment, of having also intraoral manual therapy, bilateral temporomandibular joint, and for sleep bruxism and for the TMG, the patient learned which exercise she needed to maintain, how to change stress, and how to manage posture. So this is to tell you that we don't keep the patient, of course, for us forever. We try to teach the patient the things that they need to do, and they will at first stay with us for a little longer, and then they will manage it because they learned, and they will come back only when they really, really need. So it's our effort to teach to the patients how to manage, to understand and manage their diseases so they can live better. Okay? And there is a reading material for you about that. We are going to have a 5-minute break now and then start with the narcolepsy lecture. Okay, thank you.